आ रही है आपको? Today is very important topic of this endocrinal module of third year class. The topic name is clinical presentation of pituitary tumors and their diagnosis. As far as the pituitary tumor is concerned, it is pituitary gland is concerned is a master gland, and the weight is of 0.6 gram. It is morphologically, embryologically, and functionally two distinct parts. That is anterior pituitary, which is called adenohypophysis, and posterior pituitary, which is called neurohypophysis. So these are the two parts of the pituitary gland. This diagram shows the location of the pituitary gland in the brain. That is pituitary on the left side of the diagram. The pituitary gland is attached with the hypothalamus through pituitary stalk, and the above portion is the cerebrum, and the behind back posterior portion is the cerebellum. On the right side, two part has been shown, uh, divided by means of the pars intermedia. This is just anatomy of the pituitary gland. This is also some relation with the surrounding structure that is above the pituitary gland. The pituitary gland is situated in the pituitary fossa. Above the pituitary fossa, there is an optic chiasma and the surrounding structure. I don't want to go into the detail of this. This is just anatomy. This is also one of the view, that is the corner view, which shows the pituitary gland and is just its anatomical landmarks. Very important is the embryological development of the pituitary gland. Pituitary gland is ectodermal in origin, and having the uh, anterior pituitary, that is adenohypophysis, developed from the ratex pouch. That is, it is basically upward invagination. That is the yellow strip shows the upward, the red strip shows the upward invagination of the ratex pouch is the adenohypophysis, that is anterior pituitary, and the posterior pituitary is that neurohypophysis developed from the downward extension of the diencephalon. That is a infundibulum is developed. जी बोले. अच्छा जरा मेरा लेक्चर है, थोड़ी देर बाद फोन करिएगा. Sorry for disturbance. This is the embryology of the pituitary gland. It is ectodermal in origin. Now the hormone produced by the pituitary gland. The anterior pituitary produce six hormone, that is a follicular stimulating hormone, luteinizing hormone. These are the gonadotrophin hormone. It's called gonadotrophins. And the other hormone, that is the adrenocorticotropic hormone ACTH, thyroid stimulating hormone TSH, prolactin, and growth hormone. These all six hormones are released from the anterior pituitary, secreted from and formed in the anterior pituitary. These two hormones, oxytocin and antidiuretic hormones, are produced in the hypothalamus and released or secreted from the posterior pituitary. The details of the function which are impaired in the pituitary tumor I will tell you later on in coming slides. As far as epidemiology of the pituitary tumor is concerned, most of the epidemiology is unknown, but in some cases it is associated with the environmental factor, and up to 15% of pituitary brain tumors constitute the pituitary adenoma, and 25% of the pituitary gland at autopsy found to have the adenoma. 70% of adenoma are having the endocrinological secretion. 70% of the adenoma have the functional or secretory adenoma. The incidence of pituitary adenomas are in the age of third and sixth decade, most common in women, and sometimes genetical predisposition is also there in multiple endocrine neoplasia 1. The 3% of the tumor is associated with this disease. When we classify the pituitary tumor, we classify secretory tumors and non-secretory tumors. Secretory tumors, that is the adenoma which may secrete prolactin, excess secretion of prolactin, growth hormone excess secretion, ACTH excess secretion, TSH secretion, gonadotrophin secretion, LH, FSH. and the non-secretory, that is adenoma with no apparent hormonal function, non-secretory tumors. So divided into two men. So as far as the prevalence is concerned, most commonly prevalent adenoma are the prolactin cell adenoma, prolactin secreting adenoma, 30%. Then next is the growth hormone secreting adenoma, 15%. नवान आवाज आ रही है सबको? Growth hormone cell
जी
adenoma,
सर आ रही है सर.
15% growth hormone adenoma. Then the prolactin cell, then the combination of growth hormone and prolactin, both in the same tumor, 7%. Then ACTH adenoma, 10%. Then gonadotrophs, that is FSH LS secreting adenoma, 10%. Then non-functional pituitary adenoma, 25%. That is 1/4 of the all adenomas are non-functional. TSH very small in number, that is 1%, very rare. And some unclassified adenoma are also present in the pituitary adenoma classification. We can also classify pituitary adenoma according to their size. For example, adenoma, microadenoma, when the size is less than 10 millimeter, and macroadenoma when the size is less than more than 10 millimeter. That is, we can say that less than 1 centimeter is microadenoma, more than 1 centimeter is macroadenoma. And then according to the degree of aggression, that is the degree of isolation at the site of the growth or the invasion to surrounding structure. That is the most of the tumors are benign, that is stay there, and some are invasive. That is 35% are invasive, that is surrounding eroding the surrounding structure, 35%, and only 0.1 to 0.2%, very rare, very small in quantity. The carcinoma is very rare in pituitary tumors. Then as far as the clinical features, signs and symptoms of these tumors are concerned, signs and symptoms are due to the hypersecretion or hyposecretion, and we perform lab tests to diagnose these conditions accordingly. For example, FSH and LS secreting adenomas. So there is no hypersecretion, that is a silent, hypersecretion is silent. Hyposecretion is there due to the compression effect on the secretion of LH and FSH. So what are the features of the hyposecretion of FSH LH? It is because FSH and LH are gonadotrophic hormone. They act on the gonads. For example, act on the ovaries, result and uterus, resulting in the menstrual regulation of the menstrual cycles and ovulation. Or in case of male, act on the testicles to produce testosterone and maturation of the sperms. So when there is an hyposecretion, they can produce sexual dysfunction. For example, impotence, vaginal dryness in females, impotence in male, vaginal dryness in females, infertility, mood swing, osteoporosis, and decreased libido. When this condition occur, we evaluate lab test, which should be important, are luteinizing LH, FSH, serum testosterone, and estradiol. These 4 tests are important in this condition when there is LH, FSH hypersecretion. When ACTH, adrenocorticotropic hormone hypersecretion, this is called Cushing's disease. That is, the more ACTH, more cortisol is produced from adrenal cortex. The Cushing's disease, the features of Cushing's disease are the moon face, buffalo hump, truncal obesity, lemon on the stick like the body structure, stria, hypertension, diabetes. These are features of hypersecretion of ACTH and in Cushing's disease. While when there is a hyposecretion, that is the adrenocorticotropic hormone insufficiency, they are the symptoms of hyposecretion. That is a weight loss, nausea, hyponatremia, hypoglycemia, hypotension. All the feature of adrenocorticular insufficiency, cortisol deficiency is in hyposecretion of ACTH. The tests which important to diagnose are the serum cortisol and ACTH level. And then the third hormone, TSH, thyroid stimulating hormone. When there is an hypersecretion of this hormone, there is the features of hyperthyroidism. That is, a patient have tachycardia, palpitation, anxiety, tremulousness, tremors, weight loss, all these features of hyperthyroidism is there. When the TSH is hyposecretion, for example, in this left side of the diagram, prolactin. When the prolactin hypersecretion, that is prolactinoma, the prolactin secreting pituitary adenoma is there. Then there is menstrual irregularity, infertility, galacturia, because one of the functions of the prolactin is the ejection of milk, galacturia, and weight gain. But the hyposecretion of prolactin hormone in the tumors are silent. So what lab tests are important? Prolactin level, serum prolactin level. When the growth hormones excess secretion or less secretion, suppression of the hormone due to the tumor, these features are that is hyper secretion produce uh, acromegaly in adult, that is a growth, overgrowth, tall stature, acral part, enlargement of the acral part, hand, feet, jaw, tongue, hyperhidrosis, carpal tunnel syndrome, or when there is a growth hormone excess secretion before puberty, the giantism occurs, that is tall height. On the other hand, hypersecretion of the growth hormone produce short stature, stunting of the growth, there is dwarfism, which is also called dwarfism, or an effect on the bone as well, osteoporosis and weight gain. So the tests which are important in this condition are the insulin-like growth factor and growth hormone, IGF-1 and growth hormone. These are important for diagnose this condition. Then the, as I said earlier, posterior pituitary secrete two hormone oxytocin, release two hormone oxytocin and antidiuretic hormone. So oxytocin causes the uterine contraction at the time of parturition and lactation, and antidiuretic hormone causes deficiency causes diabetes insipidus, and excess causes SIADH, syndrome of inappropriate diuretic hormone secretion. Though these conditions are rare in pituitary adenoma. Now the detail about the pituitary adenomas. First of all, prolactinoma. Prolactinoma is constituting 30% of the all pituitary adenomas, is the most commonest microadenoma, present as amenorrhea and galacturia and sexual abnormality, that is in male, erectile dysfunction and the infertility. Prolactin level more than 200 nanogram per meter is observed in hypolipidemia. Treatment is initially in the first line treatment is a pharmacological treatment, that is bromocriptine and cabergoline, and the second line treatment is the pituitary surgery. Now the indication of bromocriptine therapy: when there is a non-invasive prolactinoma and serum prolactin level is between 150 to 300 nanogram per milliliter, or when there is a serum prolactin level is very high, that is more than 1000 nanogram per milliliter, when there is a residual or recurrent prolactinoma following surgery. These are the three indications of bromocriptine therapy initiation. Then the growth hormone secreting tumor is the most common macroadenoma. Prolactinoma is most common microadenoma, and growth hormone secreting tumor is most common macroadenoma. Occur in fourth and fifth decades. Because of the excess growth hormone release, the features of acromegaly, as I said earlier, that is the acral part, enlargement of the acral part, acral enlargement of jaw, prognathism, macroglossia, and the bossing of the forehead. Growth hormone level is raised more than 5 nanogram per milliliter, and the initial treatment in the macroadenoma, that is due to the growth hormone secretion, is surgery, not the medicine. Then the corticotroph secreting adenoma, that is adenocorticotropic hormone secreting. They are 10% of the pituitary tumors, as a result of which there are symptoms of cortisol excess, hypercortisolism. Cushing disease is they produce Cushing disease, And symptom of hypercortisolism, as I said earlier, increased body weight, edema, buffalo hump, moon face, acne. These are all the symptoms. And where this condition is diagnosed by means of high dose dexamethasone suppression test and the moderately elevated ACTH level. So low dose dexamethasone suppression test is used for the diagnosis of Cushing's syndrome, not the Cushing disease. Surgery is the best option for treatment of this condition. Then thyrotrope adenoma, TSH secreting adenoma. This is very rare, less than 1% of pituitary adenoma. Manifest with sign of hyperthyroidism. There is a this is called secondary hyperthyroidism because the problem is in pituitary, not in the thyroid, resulting in high TSH and high free T4. Surgery is the first option in this condition. So as I mentioned earlier in table form, the clinical features. The clinical features and presentation of the pituitary adenoma are due to the hypersecretion of the hormone due to the pituitary adenoma, and due to the hyposecretion of the hormone, and due to the mass effect. So mass effect produce headache, that is the pressure on or a diaphragma celli produce headache, frontal headache. Loss of vision, that is compression of the optic chiasma, that is surrounding structure, erosion of the surrounding structure, resulting erosion of the optic chiasma, resulting in the loss of vision. When the erosion or compression of the third ventricle, there is a hydrocephalus. When there is an involvement of hypothalamus, erosion of hypothalamus, then there is an hypothalamic syndrome, that is sleep disturbance, mood swinging, and abnormality alertness. So how we diagnose this pituitary adenoma? We have got imaging, for example, MRI brain with and without contrast. When we do MRI brain with and without contrast, the the contrast include the tumor enhances less, that is pituitary tumor enhances less as compared to surrounding tissue. So it can visualize easily. And the hormones which we can check to diagnose our cause of pituitary tumor, depending upon the clinical features of the patient. For example, key feature of the hyperprolactinemia is there, galactoria, infertility, sexual deficiency, prolactin level. Then accordingly, these tests, that is LH, FSH, growth hormone, ACTH, testosterone, growth hormone, cortisol, dexamethasone suppression test. These are the laboratory tests to diagnose the different prolactinomas or adrenal adenomas. Visual field defect examination is very important. It's performed by ophthalmologist. Very important visual field defect occur in pituitary adenoma uh, is bitemporal hemianopia. Bitemporal. The temporal field is lost due to the pituitary adenoma. Why it is hardly lost? Because the tumor erode the optic chiasma having the decussating fiber. So half of the lateral and half of the medial side, both medial side of the are decussating at the optic chiasma, resulting in the loss of the bitemporal area in the when there is a tumor eroding the pituitary tumor eroding the optic chiasma. Most common features. That is this is the visual field perimetry of patient having the pituitary adenoma in the initial stage. That is there's the blackest area. The lateral field is lost. Lower quadrant is lost. A small portion of the lateral field is lost in initial stage. After 9 months, whole of the lateral field. This is typical bitemporal hemianopia caused by pituitary adenoma. This is patient vision is like this. Patient can see the medial portion, that is the medial nasal portion of the both field, but not able to see the lateral portion, temporal portion of the visual field in patient having the pituitary adenoma. So this is a MRI showing the enlarged pituitary gland involving the pituitary fossa and surrounding structure. This is macroadenoma. This is also feature of the macroadenoma surrounding the adjacent structure, eroding the adjacent structure surrounding the pituitary gland. Then the treatment. The we have three options, that is surgical excision, radiation, and medical therapy. Generally, first line treatment is surgical excision, most of the cases, especially in patient having the growth hormone secreting pituitary adenoma. Drug therapy available for some functional tumor, for example, prolactin secreting prolactinoma. Simple observation in few cases, for example, we have option of simple observation if the condition is not in the initial stage. For example, we have this option when the tumor is small, does not having local mass effect, does not eroding the surrounding structure, very small microadenoma, and is non-functioning, doesn't cause any sign and symptom, non-functioning microadenoma. No, or tumor not associated with clinical features that affect the quality of the life. So we can observe in such condition, we can observe the patient, we can call the patient in follow-up visit and check the symptoms and investigate looking for the severity of the disease. What are the aims of the surgery? The aim of the surgery is to reduce the mass effect produced by the large tumor over adjacent structure. Very important. First is to reduce the tumor mass. Second is to inhibit the hormone secretion. That is the excess hormone causing symptoms. Inhibition of to inhibit these hormones, they reduce the hormone secretion. And number three is to preserve the morphological and functional integrity of the pituitary, to preserve the anatomy of the pituitary, to avoid the erosion of the surrounding structure. In surgery, we have two options: transcranial approach or transsphenoidal approach. In large tumor with extracellular extension, the aim is to reduce the tumor volume and have greater number of complications. So in the large tumor, transcranial approach is required. It has a complication because approach is through the skull. And in nowadays, transsphenoidal is a approach of choice, especially in the small tumor or medium-sized tumor. The treatment have no complication in a skillful hand and preserve the pituitary function, and it is not if the not pituitary is previously affected. The cure is 90% if microadenoma. If microadenoma, cure is 90%. Tumor reduction without complication, cure is in large tumor. In large tumor, tumor reduction without complication, and in small tumor, 90% is the cure. This is a transcranial approach, the approach through the skull to operate or to remove the pituitary tumor. This is a transsphenoidal approach. That is in the transsphenoidal there are two type of different approach. One is the sublingual approach, like this, through the mandible, and one is endonasal approach. So two type of the transsphenoidal approach. The indication of surgery: when there is progressive mass effect, there is a mass effect producing headache and different features, visual field defect. So this is the indication of the surgery. A failure of the pharmacological radiological therapy is a second indication of the surgery. For example, failure of Prolactinoma improvement after bromocaptin and parallel therapy, then the surgery is the choice. Then pituitary apoplexy is a condition in which surgery is required. What is the pituitary apoplexy? There is an abrupt and occasionally catastrophic acute hemorrhagic infarction of the pituitary adenoma. There is a sudden infarction in the pituitary adenoma. This is called pituitary apoplexy. Present with acute, this condition is acute condition, present with the acute sign and symptom, that is a severe acute headache, sign of meningitis, meningismus, visual impairment, ophthalmoplegia, the impairment of the movement of the eyes, alteration in the consciousness. Patient may be unconscious. The cortisol replacement is the most important first step due to the adrenal insufficiency. In such condition, first medical therapy is the replacement of the cortisol hormone. It's very important, followed by the urgent surgical decompression. This is the picture showing the infarction within the pituitary gland. This is called pituitary apoplexy. The post-operative complication. What are the post-operative complications of pituitary surgery? The diabetes insipidus can occur. That is deficiency of antidiuretic hormone, resulting in the loss very huge amount of urinary output and sodium decrease in sodium amount. CSF leakage. That is the CSF resulting in the rhinorrhea. Excessive amount of CSF leak through the nose, rhinorrhea, and hemorrhage within the surgical site. That is this is also considered hemorrhage at the site of the surgery. These are the post-operative complications. Thank you all of you for your patient hearing. Any question? Any question? Naman? 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 Are all of you are here? If there are any question, you are welcome. You can ask me question on chat. You can write your question. I'm here to give answer your question. What is the time? 11. So, Naman, are you hearing? Naman, are you there? आवाज नहीं आ रही। Any student? बच्चों आप सुन रहे हैं सब? किसी one Yukashal Fatima. From Prolactinoma, medical therapy with bromocaptin is the first option or surgery. Yeah, very important question. Medical therapy, pharmacological therapy, bromocaptin. Very important. First of all, we start with the dopamine receptor agonist bromocaptin before the surgical therapy. If there is no response for the bromocaptin, then we have to do second line as surgery as a second option. Any other question? So if there is no question, so I am now I'm resuming. Can please tell me the type of surgical approach? As I said earlier, Muhammad Waqas asked a question. Tell me the what are the type of surgical approach? Surgical approach, as I tell in the last slides, there are two type of surgical approach: trans method, and pituitary gland can be approached easily because it is behind the sphenoidal bone, and there are two type of the approach: nasal approach as well as the sublabelus approach. Any other question in the chat box? Okay, thank you all of you. Now I stop my lecture. Thank you.